And thank you for joining the International Organization of MS Nurses, the Consortium of MS Centers, and NeurologyLive today for differing perspectives on multiple sclerosis nursing care, the patient program. We'd like to extend our thanks to Biogen, Squibb, Genentech, and Novartis for supporting this program today. I'm Denise Bruin. I'm a nurse practitioner and certified MS nurse at the University of Virginia, where I am the medical director of the MS clinic, and I will be your chair today. I am joined by Marie Namey, who will be on telephone today. She is a long-standing team member at the Mellon Center for Multiple Sclerosis Treatment and Research at the Cleveland Clinic. We also have Stephanie Agrella, who is an adult nurse practitioner and certified sclerosis nurse at the Multiple Sclerosis Clinic of Central Texas, where she is Director of Clinical Services. I have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the portion of the presentations. You can submit questions by typing them in the Q&A box, which can be found at the bottom of the webcast window. We will try to get to as many of your questions as we can. The slides will advance automatically during the event. If you have any technical problems viewing or hearing the presentation, please use the Q&A feature to communicate with the team who can help you troubleshoot. We've already had a few issues this morning, and if I go off screen, just know I will pop back on. Okay, let's get started. So the first topic that we are going to talk about today is disease-modifying therapies in MS. The goals of disease management are to reduce relapses and prevent or slow down progression. We also treat serious relapses, assess and manage symptoms, and our goal is to improve the patient and family's quality of life. So relapses and relapse management. Oftentimes patients will ask me, what is a relapse? So the definition of an MS relapse is an episode of focal neurologic symptoms that lasts more than 24 hours continuously without another explanation, and that the patient has been stable neurologically for at least the last 30 days. It also is beneficial to know that the patient should not have a fever when this is going on. Typically, neurologic symptoms over days to weeks. It usually plateaus at 1 to 3 weeks, and then recovery can be 4 to 12 weeks. Some symptoms might persist and become permanent. Symptoms might take months to resolve. Common symptoms of relapses. So spinal cord lesions about 50% of the time, and these are sensory or motor issues. Sensory can be more common, where there might be numbness, tingling, almost like a temperature dysregulation where things are hot but feel cold or cold but feel hot. Sometimes people can have hypersensitivity where they can't stand to have shoes on their feet. Sometimes people can have a band-like sensation where they feel like they have too tight of a shirt on, and they can call that the MS hug off. Bladder and bowel dysfunction can be common, where patients have trouble controlling their bladder or don't feel like they empty. Neuritis can be common, and this is typically one eye at a time, and it is painful vision loss. So sometimes patients will describe this as a veil. Sometimes they will notice that one eye is blurry versus the other, or that green does not seem as vibrant in one eye versus the other. Patients can have brainstem relapses. So this can be having double vision, or somebody might notice that looking at the family member that their eyes don't quite seem to work together, or there might be a little like tremor in the eyes, which is nystagmus. People can also have trigeminal neuralgia, which is pain on one side of their face from a nerve that's inflamed. Just because we list these does not mean that these are all going to happen to somebody living with MS. So a pseudo-relapse. So this is not a relapse that we think patients are faking, but what this means is that there's something else going on in the patient environment or other system that is making their MS symptoms worse. So it's transient worsening or a return of neurologic symptoms. Typically, this can be caused by having a fever, an infection, stress, not having enough sleep, physical exertion, getting overheated, certain medications, sometimes surgery can cause this. I've had patients doing colonoscopy prep that have found that their symptoms have worsened temporarily. And some women also report they have more symptoms in their menstrual cycle. So it's important for us as the healthcare providers, along with the patient, to assess, is this a relapse or a relapse or something else going on? So we're going to ask patients a lot of questions. When did it come on? Did it come on suddenly? Have other things been happening to you? Is it a hot, humid day in the south and your air conditioning went out? That can make symptoms worse. How severe is it affecting that you can't drive or walk? Or is it just that you're just going up and down stairs, that it's a little bit different than it was a few weeks ago? And then we have to decide if this is a relapse, how we're going to treat that. Often we will give patients high-dose steroids. This typically is through an IV at an infusion center or having home health come to the patient's home. They receive 1 gram or 1,000 milligrams, same thing, a day for 3 to 5 days, depending on provider preference as well as severity of the relapse. Sometimes we'll give oral steroids in very high dosages. This has probably become a little bit more common within the pandemic. We do know from previous trials that this is safe to do and patients tolerate. Usually the hardest thing is having the pharmacist that's dispensing the oral steroids understand that, yes, we did mean to order such a high dose and how we want the patients to take it. And sometimes we use something called ACTH, which is an injectable medication patients give themselves at home that help their body make their own hormone to help fight off the inflammation. We don't usually do an oral steroid taper, so this would be after completing the high-dose steroids, where patients then subsequent days start taking a lesser and lesser amount of steroids. When we give steroids just over 3 to 5 days, it's not always necessary to do a taper, although some patients do find that it helps prevent kind of a crash feeling when steroids are done. So if you receive steroids, it's important to discuss this with your provider, especially that you taper versus. So side effects of steroids. Some patients really like steroids. The positive side effect is that it gives patients more energy. It can help with other types of pain. Goal of steroids. Steroids, again, are to decrease inflammation going on in the central nervous system. So adverse things that can happen, some more rare than others. So vascular necrosis of a joint. So this is to death in a joint. Most commonly, it can be in a hip, and it would mean that someone might need a hip replacement. Again, this is rare, but it is important to know that this can happen. Patients definitely will have high blood sugars when receiving steroids. This is a very common side effect, as well as increased white blood cells temporarily. It can also cause low potassium, fluid retention, and with that can then cause high blood pressure. Some patients have upset stomach from steroids where they get heartburn, or they will feel kind of just upset, nauseous, increased appetite. Sometimes patients can have increased anxiety. Trouble sleeping is a very common side effect from steroids. Long-term steroids can lead to cataracts, glaucoma, retinal necrosis, and this is usually with long-term or frequently repeated use of steroids. People can be more prone to osteopenia or osteoporosis, which is thinning of bones. And then skin can also be affected by steroids. So many people have some acne temporarily after receiving steroids. It can also impair wound healing and make skin more sensitive and thinner, and that's usually more with long-term use of steroids. Okay. So once we've decreased that inflammation with relapse, that new lesion, we look at what else do we need to do to help the patient recover from a relapse. So oftentimes this is with physical therapy and occupational therapy. Studies have shown that doing physical therapy after relapse actually improves the recovery, even if it's more of a mild relapse. Exercise is always a good thing to help the body. So physical therapy might be looking at mobility, safety, stretching, occupational therapy, different equipment, aids to help maybe put a shoe on, buttons if somebody's lost like sensation in their fingertips. Occupational therapy can also help with fatigue management, and many occupational therapists are also trained with low vision. So if patients did have optic neuritis or double vision, they can actually give on dealing with that day to day. On occasion, we'll have speech therapy see patients if they're having trouble swallowing or with their speech, and sometimes just with cognition. Social work can be helpful with managing resources. What does this look like being out from work if you need treatment or time off after a relapse? And we sometimes will do inpatient where we actually have to admit somebody to a hospital for a relapse, but most of the time this is all managed as an outpatient setting. So disease-modifying therapies, or DMTs. So these are kind of the crux of what we do and talk about when we see patients in the clinic. So the goal of these therapies, they're not a cure. They're not going to repair the damage that may have been done from somebody's MS. These are to alter the course of the disease. So the goal is by eventually getting patients on the correct DMT, we will prevent patients from having new or more relapses or new lesions by causing new issues and delaying disability progression. So we have 2 pages of disease-modifying therapies now. Some of these you might have heard of in the past. Some of these now have generic versions of them. But again, the goal of all these is not to repair, necessarily improve how a patient is functioning, but to prevent patients from having further issues. These are either through a self-injection that a patient gives himself at home, a pill, or an infusion. Most of these, as you can see, are for relapsing forms of MS, although more of them are becoming available for progressive forms, both secondary and primary progressive MS. These are some of the newer ones that have been approved.
So it looks like Denise may have had a little bit of a connection issue, but I think she was reviewing the oral therapies or some of the oral therapies that are fairly new, listed here both by generic name as well as the administration regimen, and then also kind of reviewing what they're indicated for relapsing forms of MS or clinically isolated syndrome. Denise, I'll turn it back over to you.
Thank you, Steph.
Just wrapping up on the indications.
I appreciate it. Okay. So, given 20 different options, how do we decide which drug? And this is kind of an ongoing debate in the MS arena. So it's all about balancing what to the patient, what else is going on with the patient, and what are the side effects of the therapy we're looking at? How is it delivered? Is the benefit of that medication outweigh the risk, or is it too risky and need that to get that? So we're always weighing this. And this might be a different discussion when a patient is first diagnosed versus several years into their diagnosis. So injectable therapies have been around the longest. Some of people that are on this call might have been in the original lottery to try to get on the first DMT that was available in the early 90s. So the most common side effect with injectable therapy can be site reactions. So obviously we're going to show you some of the worst we've seen here, but most of these, we're showing you the legs here, but it doesn't mean you can't be in other places, but you can get a reaction in the subcutaneous fat from medicine. It's usually not so much that the patient did the injection incorrectly, but this can just happen anytime the skin is broken. So you can see there can be redness, swelling, you actually get some scabbing or almost burn-like to the site. So this can be difficult for patients to want to continue or be adherent to their therapy if they keep having these types of issues. Imagine doing this 3 times a day and having these spots, kind of all over you. So this is where MS nurses can really be beneficial with helping patients with their injections and trying to minimize these types of reactions. This is from glatiramer acetate, some of the, again, the worst kind of reactions you can see. On one, we're actually looking at, it's not the inside of an elbow, but it's actually the back of somebody's arm, kind of in here, where they're actually getting lipoatrophy. So the fatty tissue has actually kind of been eaten away by acetate to the fatty tissue there. The stomach, again, some redness, kind of some burning, and then the photo in number 3 is to show you some of the swelling, like a really bad mosquito bite. So again, there's different things that nurses can do to help minimize these types of reactions. And if somebody otherwise is doing well on these injections with their MS, we try to help prevent this as much as possible to keep somebody on the therapy that's working for them if it is. Next, we have oral therapies. And I think all these are on here. Again, some things have been approved since some of these slides were made, but many of these you might have heard of. This kind of goes through how they're dosed, some of the common side effects that we know of, some of the more serious side effects that could happen. We don't really have pregnancy categories anymore. This pertains to what the risk would be to the fetus if the woman got pregnant while taking these therapies. And then with any of these medications, they're going to be monitoring either before starting drug or while the patient is on the medication. Another list of the therapies, side effects, common and rare, pregnancy category, and then monitoring that's needed. Then we have infusible therapies. This has one medication that was approved 2 months ago in this country. That's actually not on here. It is a subcutaneous injection, but it fits more in line with the IV infusions. And so that one we'll make mention of, but that is ofatumumab. So we'll need to add that to this slide as well. But these infusions are given either every 4 weeks, every 6 months, or dosed over a 2-year period, depending on what drug is at hand. As you kind of look through these different treatment options, you might notice that with the more effective therapy, see some more serious side effects. So again, there's that whole balancing of what's best for the patient at hand. Other things we consider, so with fingolimod, it can cause transient lowering of the pulse, so you do have to be monitored the first time you take it. This is rare, but we still need to do this. Patients are observed for at least 6 hours after taking the dose. They have EKG, looking at their rhythm pre and post taking it. While they're on therapy, obviously we want to know if there's infections because it does lower the white blood cell count. The flu shot is not live. We recommend almost all of our patients to talk to their provider about getting the flu shot. It's also recommended that people get an eye exam before fingolimod and then 3 to 4 months after being on it. Or another very rare side effect of macular edema. This was approved in 2012. There could be men and women trying to have a baby. Obviously, if the man is on teriflunomide, there could be risks with his partner being exposed to teriflunomide, so you want to talk about with the healthcare provider. And then if women are on this medication while being pregnant, it's also not to be safe, so there's other things that you would want to do. It is slowly excreted, which in some ways is a good thing because if a patient misses a pill here or there, it's not like it's out of their system immediately. It can actually be detectable up to 2 years in somebody's system. But there is a way to get it out of their body if we needed to within about 11 days. If, for instance, we did find out that our patient was pregnant taking it, we could safely get it out of their system. Sometimes we use other therapies FDA approved for MS. We did this a lot more before we had all of these great options. So drugs patients might have heard of or might have been on before or might still ask about if they've been on Google looking at things. So these you might see out there, but they're not very commonly used to treat MS because they are off-label use. So again, there's risk and benefit with these medications. So one very rare risk that can occur is something called PML, or progressive multifocal leukoencephalopathy. This is a very rare violation of the brain. It can happen in any, not just MS, but anything that has a suppressed system. So the majority of literature that we have about PML is in the HIV population. It's a very different population than patients with MS. We think that this is called the JC virus or the John Cunningham virus, which is just a virus that lives out in the community. It typically doesn't really do anything until we start suppressing somebody's immune system, and then the virus can become active. So in some of the disease-modifying therapies we use with MS that suppress the immune system or prevent the immune system from being in the brain, we can see where this infection can actually become active. Symptoms of it can be very similar to an MS relapse. So again, this is why we see our patients frequently, touch base with them. There is a monitoring program to be on certain medications where this risk is higher. And this is also why we do MRIs, just to look at stability of somebody's MS, but also to make sure we don't see anything else in terms of a side effect from the treatment that they're on. To actually diagnose PML, though, if it's suspected, would be a spinal tap to look at the cerebrospinal fluid for replications of the JC virus. So again, disease-modifying therapy to prevent new patients from occurring, to hopefully slow down any progression. Two kind of different buckets where we are modulating the immune system. So we're just kind of tweaking it a little bit. So change the response of the immune system to therefore prevent relapses. So gluteramine acetate, interferons, and dimethylfumarates, diroxylfumarate, and monomethylfumarate are all thought to be immunomodulators. And then there's immunosuppressants that actually suppress the immune system or prevent the immune system from going into the central nervous system. So those medications would be mitoxantrone, which you don't really use anymore because there's a lot of cardiac side effects. Teriflunomide could be considered in this category, fingolimide, ozanimod, and there's, I forget there's one other in that category, ocrelizumab, natalizumab, alemtuzumab, and ofatumumab would all be considered immunosuppressants. They actually cause lowering of white blood cell counts, or we know where they work in the immune system actually cause some suppression. So you have to remember that MS is a lifelong disorder. So treatment is a lifelong commitment. Patients will often ask me, do I need to be on this the rest of my life, whatever therapy they're on? And the answer is probably, unless there is something better that comes along, if there's reason to stop that or change their therapy. But this, again, right now there is no cure for MS, but there are a lot of great treatments to make it so that MS is just something you're living with and not having to necessarily be concerned with. It's important that patients are adherent to their treatment plan, that they take their prescribed. It's important for follow-up appointments, even if somebody's feeling really well, because there's monitoring we want to do to make sure no other issues come up while they're taking their therapy. Communication is key, not just with your neurology practitioner, but also with your primary care provider. It's important that you keep up with them so that you get your vaccinations and that other health things are taken care of appropriately. Find a strong support network. This can be through venues like this, where you're learning about your disease, and there's people on here also living with MS. It can also just be knowing who is on your medical team and who in your family or friends is there for you to understand kind of what you're dealing with. You want to have a health and wellness approach. So this is, again, eating well, not smoking, taking your vitamins, getting outside in the sunshine, moving your body, exercising, sleeping, maintaining good relationships, all those things that are important to all of us, whether we're living with MS or not. So in conclusion for this first part of today's discussion, it's important to focus on disease management, reduce relapses, we want to manage symptoms, and slow of disease, because our overall goal is to improve and maintain a patient's quality of life. Depending upon severity, different treatments might be required. Oftentimes this is with steroids, but also usually with some symptom as well as PT or OT. And the goal of disease-modifying therapy is to reduce the frequency and severity of relapses, decrease lesion activity, and delay disease progression, or something we call NEDA, which is no evidence of disease activity. Okay, so I think we have time for a few questions on this part.
So Denise, one question that I saw was a question about PML, progressive multifocal leukoencephalopathy, and what on the MRI can show evidence of PML? Great question.
Yeah, let me go back to some of these pictures here. So if you see on the top pictures, oh, hold on, I want to go here. Okay, you can see these MRI pictures. So you can see, hopefully, that with PML, it looks kind of fluffier and much more, where all that white is on the right side, fluffier, and it's much more diffuse on that whole side of the brain. Whereas MS lesions typically would not be this large. They have a different quality to them in terms of the edges being much more obvious. And so if somebody showed up with this type of MRI with symptoms, and if they were on a treatment that made me suspicious for PML, they're probably going to have a spinal tap to help answer that question. But there are differences on the MRI. This is pretty extreme what we're seeing here. It obviously starts off much smaller. There are many thoughts that if somebody has changes on their MRI and they're on a therapy that is known to have PML as a risk, that we need to investigate as PML until we know otherwise. If it's treated early, it's a much better outcome. Other thoughts, Stephanie or Marie?
I think it just really highlights the importance of us with monitoring and the need for MRI for not complete monitoring, because obviously we still need to do an assessment and see an individual who's living with MS that's on a particular therapy that we know has a potential risk for PML. But it also really highlights the fact that we do want to do this routine MRI imaging to assist us with picking up on these things earlier, if possible.
Yeah, great. There is one other question we can't quite answer directly, but it alludes to if there's changes on MRI and the technique of the MRI is different, how do you know when to kind of do something different? Which is a great question. So I think with anything, my advice is measure twice and cut once, and to take the whole patient into consideration that's in front of you. Second opinions are often, recommended. Sometimes too many opinions, because then you keep looking for an opinion till you hear what you want to hear. There is question about the results. It's always best to recheck, whether that's blood work or an MRI. There's one other question: is there a cure or is it fatal? So this is a great question. So again, as I mentioned, most of the PML literature out there is in the HIV population, which is very different than compared to MS. So in HIV, it is almost always fatal, because you can't make an immune system for patients dealing with HIV and PML. So in MS patients, it is not always fatal. Getting it found earlier is always best, because then we can either start reversing the medication that they were on for their MS, so the immune system can clean up the infection. There's a lot of different research looking at how to treat PML. There are some experts in this country. The MS community is small, so we often reach out to each other for help and advice. But there is no true PML, but there are different therapies that we're looking at and different protocols that we can eventually have on the books if somebody does have PML. I'm going to answer one more question, then we'll switch to Stephanie here. What's the best MRI for MS and PML check? So more and more, it seems that most facilities are doing a Tesla 3T magnet instead of a 1.5. So this is also where that previous question about the MRI differences can come up. So if somebody has an MRI on a 1.5 Tesla and then on a 3 Tesla, you're going to see more. So how much is it just a better quality picture, and how much is it potentially that the patient's having changes? So if possible, I would do a 3T Tesla if there is a concern of PML. There was also a question about the type of contrast that's been used. I don't know. Our facility uses Gadavis, but I know that there are some that there's concerns about the well-being of brain tissue, but I don't know enough to answer about the type of contrast in diagnosing PML. I don't know if Stephanie or Marie, if you have any thoughts about that.
So we use Gatavist as well. I am not aware of there being an issue where we need to use a particular type of gadolinium in order to pick up on that. I've not ever read anything to suggest so.
Yeah.
So this is Marie. The concern was that gadolinium accumulates in the brain over time, and that actually turned out to be true. But the other question is, well, is that harmful? And the answer to that has yet to be determined. So there is not knowledge that the little bit of gadolinium that might accumulate in the brain ends up being harmful. In lots of studies over the years, patients were given or having MRIs done very often, like every couple weeks, every month. We certainly don't do that in clinical practice. Every 6 months or every year is pretty much the standard. We use Gatavist at our center also, but I don't think there's one gadolinium that's dangerous or best, is the short answer.
Mm-hmm. And really, if PML is suspected, a spinal tap is indicated. Okay. Great questions, guys. So we're going to move on to the next part of this morning's lecture, which is symptomatic management in MS.
Okay, so that's me, Marie. I'm up now, and I apologize. I am so sorry I cannot get my video to work, but hopefully you will all be able to hear the information that I would like to share today. So you heard earlier from Denise that the disease-modifying therapies do not make symptoms go away. So unfortunately, when there are lesions or footprints of MS in the brain or spinal cord, symptoms may sometimes get better initially, but over time they may not. And the goals of symptom management are really to eliminate or reduce symptoms that impair functional ability and improve quality of life and avoid secondary complications. So if a person is having trouble walking, we certainly don't want them to be at risk to fall and then, oh gosh, break a hip or an arm or something like that. And it's really important to use individualized treatment of symptoms. That's really what's essential in the management of MS. Lots of people who have MS have the same symptom, but how that symptom affects you in your day-to-day life is certainly unique to you. It's a whole team that is needed to take care of folks who have MS. It takes a village is what we often tend to say. And the patient and family are the center of that team. So your hopes, dreams, concerns, worries are the most important thing. And all of those people surrounding you may have input into your care at one point or another in your journey with multiple sclerosis. Certainly we hope that everyone has a neurologist. We as nurses would love that you had a nurse practitioner, advanced practice nurse working alongside, and a pharmacist, psychologist, social worker, physician assistant, speech-language pathologist, other folks in rehab, occupational therapist, physical therapist, under a physiatrist, a urologist is possibly helpful too, an orthotist. And it's also really, really important that you have a primary care physician. So you, as a person with MS, it's very important you have your MS team directly for your MS, but it's also quite important that you have your primary care physician to manage those other things that are unique to you and make sure that you're in the best health as possible. Listed here are a breakdown of symptoms. Primary, meaning they come directly as a result of MS. Some secondary concerns because of some primary symptoms. Other things might happen. And then some tertiary symptoms along the way. And so depending on where MS symptoms or MS lesions are in the brain or spinal cord, people may have those primary symptoms. We know fatigue is is a very common symptom. 80-90% of people with MS have fatigue. Bowel, bladder, and sexual function concerns can be primary symptoms of MS. Cognitive changes, changes in thinking and memory can certainly occur because of MS. Spasticity, what we in the healthcare world call spasticity, you might call stiffness or tightness in your legs particularly. Altered mobility, difficulty walking or moving, vision disturbance, and then an odd sensation, whether it be numbness, tingling, itchy, pain, however you happen to describe it. And then secondary symptoms come because of those primary symptoms. So as I mentioned earlier, if your walking is a bit off, you may fall and then break something. If your bladder's not working right and you're not emptying your bladder completely, you may end up with a bladder infection. If you're not moving and you're sedentary and your bones are pressing against the skin in your bottom area, you may end up with skin breakdown. And pain may also occur. It could be primary, that burning neuropathic pain, but it could also be secondary. So if you're not walking right and there's like a little hitch and you're giddy up, as one of my patients' husbands said, maybe your walk is off and you're putting too much pressure on your low back and you're developing back pain. The tertiary symptoms of MS sometimes are difficult for patient and healthcare providers. Losing a job, losing the intimacy with a partner, changes in your family and role because of some of the sequelae of MS, depression, and social isolation. But those are as important symptoms to address as those primary symptoms. Sometimes it takes more time, a little more difficulty. We may even need to bring in other healthcare providers for you. But nonetheless, these are all quite important symptoms. So we'll start with some of the symptoms that are really near and dear to my heart. I have taken up talking about bladder, bowel, and sexual function concerns in people who have MS in my career. Bladder dysfunction occurs often, 70 to 80% of people who have MS, and it's categorized as a neurogenic bladder. So people have either inability to store, inability to empty, or a combination of those two types. Some of the symptoms from inability to store and inability to empty sound the same. People might have urgency, meaning you got to go. Frequency, you go often. Incontinence, you leak urine. If people have an inability to store, they don't have much post-void residual when we do a check to see if there's anything left over. They tend to only have a little bit that their bladder can handle, and then they have to frequently go to the bathroom. With inability to empty, some of those same symptoms occur, but now maybe you got to go quickly, but when you get to the bathroom, you just can't seem to get the urine started. Or maybe you go to the bathroom and then you think you're emptying and then you stand up and you feel you have to go again, or you just get ready to walk out the door and you have to go again. That's double voiding. Or that could be an incomplete emptying. You thought you were empty, and then, oh my gosh, a few minutes later, you need to go again. Often people who can't empty their bladder wake up often at night to go to the bathroom. Nocturia is the medical term. Nighttime voids is what people call it. It's pretty normal for a woman to wake up once at night to go to the bathroom, but more than once is more than comfortable, and it could affect certainly fatigue, and it could interrupt your sleep. People who have inability to empty may have bladder infections because there's some urine, and urine's a waste product that's sitting there, and more bacteria is growing. A combination of inability to store and inability to empty, again, you could have symptoms that are all over the place. So what's important is listening to the symptoms that you report when you come to your healthcare provider, and I would encourage you, if you're having problems with your bladder, please bring it up to your healthcare provider. Sometimes when MRIs are important and disease-modifying therapies are important to discuss, and they are, things like bladder and bowel and sexual function concerns don't get addressed. And they are really part of your day-to-day experience and can impact quality of life issues. So I encourage you, if you're having problems, bring it up with your healthcare provider to get help or get referred to somebody who can help you. Sometimes a bladder infection can cause your bladder not to be working as it had been working well in the past. Sometimes there are other things that cause bladder problems. Women who've had children who've had multiple pregnancies can have relaxation of the pelvic floor muscles. If there's a lot of weight put down on that pelvic area, it might expand that sphincter that needs to nicely close up and be tight before urine leaks out. Men can have problems with an enlarged prostate. Also, diabetes can interfere with bladder function. One of the symptoms of diabetes is not having as good control of your bladder. So there's other conditions that might affect bladder. A way to track how your bladder is doing is to keep a bladder diary. And I have a picture of that in the next slide that you can see. Just keeping track of what you're drinking and how you're going might give you some insights into what's going on. To really sort it out more than what the report is of symptoms, evaluation in the office could be somebody in your neurology office is adept at doing this, or maybe you need to see a urologist. We ask people to spontaneously avoid going to the bathroom. We measure that amount of urine, and then we have you come back to be tested with an ultrasound, a bladder scanner. It's an external device that is moved over your bladder area, and it'll pick up the water content in your bladder and lets us know how much urine is left over. Lets us know, did you empty or not completely empty? And then that gives us an idea of if you have more of the inability to void or inability to store or inability to empty. So here's a sample of a bladder diary. If you really want to keep track of how you're doing, you can look on the internet and type in sample bladder diary and come up with something if you want to be monitoring how you do over time. There's a variety of treatments for bladder dysfunction if you are unable to hold your urine. Sometimes, many times, people don't drink enough fluid. I don't necessarily recommend this particular intervention because our bodies need fluid for complete metabolic function. We need about 1.5 to 2 quarts of fluid a day. If you can't hold urine in your bladder, then you likely need to take frequent bathroom breaks. You need quick access to the bathroom. Some of you may be wearing protective undergarments. One hint that may help is to decrease the use of bladder irritants, meaning things we drink like caffeine, alcohol, or aspartame. I'm not saying don't drink coffee or don't drink Diet Coke, but you can't make all your beverages of the day or the majority of the beverages of your day include caffeine or alcohol or a fake sugar because there are consequences to what you do put into your body. There's also a variety of medications that can help allow you to hold more urine in your bladder before that muscle starts to have some irritability. If you have inability to empty, if you are not completely getting rid of all the fluid in your body, we recommend certainly that you have enough intake during the day because you constantly want to exchange that fluid in your bladder because urine is a waste product, and if you hold it too long, it may continue to grow more bacteria and you can have bladder infections. Sometimes we just say, take yourself to the bathroom every hour and a half. Drink something, and in 10 minutes or so, 6, 8, 10 ounces, and then an hour and a half later, go to the bathroom and try to empty it out. Some people need a mechanical device like a catheter, intermittent, to get out the urine by gravity. Some people need an indwelling catheter, something that will constantly keep the urine out of the bladder. There's some medications, oral medications, that can possibly work, and they're listed here. Flomax and Cardora, which are really more cardiac medications, but what they can do is relax those muscles to help you empty better. There's also popularized some Botox, blocking those nerves in the bladder to help keep your bladder working a little bit better. But basically, these are the key elements. Drink your fluids all at once. If you sip, you're going to feel to go often. Because as little amounts of urine trickle into your bladder, you may feel that you need to go often. Again, try to avoid about 1.5 hours after you drink. Stop drinking fluids about 2 hours before you go to bed, and then try to empty your bladder right before you go to bed. Because it is not normal to leak urine, wake up more than once at night to void, or have frequent bladder infections. Typically, if a person who has MS has a bladder infection, they have worsening of their MS symptoms. A typical bladder infection may cause burning, frequency, back pain, cloudy urine, pain on urination, fever, or nausea. But sometimes that's not the case with MS. Sometimes a bladder infection in people with MS can make their symptoms worse. So if you suspect you have a bladder infection, call it out to your healthcare provider so you can get treated early. So 1.5 to 2 quarts of fluid a day. Water is best. Decaf tea or fruit juice is okay. Avoid those bladder irritants that I talked about, caffeine, aspartame, and alcohol. But smoking is a bladder irritant too, and limiting fluid intake can also be harmful. So I think I talked pretty much about all of those bladder dysfunction issues that we have. Let's move on to bowel dysfunction, which is another common symptom. 60% of people with MS can have trouble with bowel function, and the most common symptom is really constipation. Sometimes there's diarrhea. Persistent diarrhea is usually caused by something else. It could be the flu, something you ate that didn't agree with you. So again, not all symptoms are due to MS. Sometimes people have involuntary bowel. Their urge comes on so suddenly where there's hardly an urge, and they leak stool. Symptoms from the bowel can be intermittent or constant, and they can occur at any time during the disease. Slow bowel constipation is the most common event. Sometimes constipation is caused by other medications that you're taking for other things. Some of those medicines that were listed for your bladder, actually one of the side effects is constipation. So you want to be wary of the good effects and the side effects of your medications. If you're not moving around as much, if your activity is decreased because of MS, that may also tend toward constipation, because for bowels to move regularly, you need the fluid, 1.5 to 2 quarts. You need fiber, 20 to 30 grams, and you also need activity. So if you're short on activity, you really need to make sure you're taking in enough fluid and fiber. Bowel incontinence can be very, very distressing, and patients need to be helped with that. The sphincter control is diminished, or maybe there's too much irritability of that area of the body. I mentioned the interventions for constipation. I prefer people eat real food for their fiber. I think nutrition is very important. So fruits, vegetables, and grains can give you fiber. You can add bulk forming agents if the natural fiber that you're taking is not enough. Stool softeners, stimulants, laxatives, suppositories can be helpful too. But my first intervention is the fluid and real daily fiber. If you're incontinent or involuntary of your bowel, sometimes medicines that slow down that gastric motility can help. Sometimes I recommend to patients that they use a simple glycerin suppository to get the stool out that's sitting there so they don't have to worry about an accident later in the day. But you would have to be trained on the use of a suppository. And then try to set up a structured program for yourself for timed bowel movements. It takes time to get a bowels working back as well as you'd like them to. Takes maybe 2, 3 a month, weeks or a month or so. So moving on to a more sensitive topic here, sexual function concerns in MS, which occur pretty often. Approximately 50% of women with MS have sexual function concerns. 75% of men have sexual function concerns. And this can hugely impact quality of life and often an overlooked symptom of MS. Maybe the patient, maybe you, the patient, are embarrassed to bring this up to your healthcare provider because you think it might be embarrassing to them, or maybe you think it's not as important as some of these other things. Maybe your healthcare provider is embarrassed to talk about it too, but somebody's got to bring it up. So I would advocate that you practice, if this is a concern for you, to say something like, I want to talk to you about my sexual function concerns, and share it with your healthcare provider. If they can't help you, ask them to recommend someone who can. Men and women can experience difficulties, a decrease in libido, that desire to have relationships. Men can have a decrease in erectile function and ejaculation. There can be an alteration in the sensations around the genital area. Women and men can have a decrease in frequency and intensity of orgasm. Women often report a decrease in vaginal lubrication or clitoral engorgement. There may be reports of increase in bladder spasticity and an increase in depression, which makes everything even more complicated. It's important to exclude other medical causes. Diabetes also can affect sexual function concerns. Some of the management strategies we have used include medications to manage symptoms, maybe some of the underlying symptoms like stiffness or tightness that interferes with sexual function, maybe managing some of the bladder problems people are having and taking away that type of concern. If people are fatigued, we can try to suggest that perhaps earlier in the day or a change in time for sexual intimacy might be better for them. Different positioning can be helpful. Sometimes a physical therapist can actually show people what might be a more comfortable position for them other than the ways that they have been intimate before. So the key is really open communication with your healthcare provider so they can offer suggestions and help and manage symptoms. Also, it's important to have open communication with your partner. Talk with them about your concerns and work together on this particular symptom. There's counseling available with sensitive support. Here's a list of medications that have been used to help with management of sexual dysfunction. Some of the older antidepressant medications have been helpful to help with the decrease in libido and the decreased orgasm. We know the medications that have been commonly used for erectile dysfunction in general have been successful for men who have difficulty, who have MS. And then there's a variety of estrogens and creams and over-the-counter help for lubrication to help with that vaginal dryness and clitoral sensitivity. So completely switching gears now, talking about altered mobility in MS. Difficulty in moving can be caused by spasticity or stiffness, weakness, problems with balance, loss of sensation, vision changes, or peripheral neurologic changes. And there can be risks of falls, There could be more pain. People may not move as much because it's more difficult to move, which leads to some more isolation and reduced quality of life. Our friends in rehabilitation therapy, those physical and occupational therapists, can be very, very helpful in offering assessment for assistive devices to help people move better. An orthotic device, different adaptive equipment, a cane, a rollator, a walker, a scooter, a wheelchair. All of these should be considered as tools and encouraged to be used. You know, people use hearing aids, they wear glasses, and those are tools to help them get around. And that's why people should consider a cane or walker or an orthotic device. Exercises and stretching can be helpful. There is a medication called a walking pill, dalfampridine, which can help those nerve impulses connect a little better and help people move better. And then if things get more difficult with spasticity and stiffness, there's some surgical options. There's also botulinum toxin that can help release those tight muscles. That spasticity is that tightness, pulling, tugging, achy muscle, and it's really related to the lesions in the brain and the spinal cord area. And different muscle groups are involved depending on the location. Often people first develop stiffness or spasticity in their legs, the lower extremities, but it can also be present in the upper extremities. And it can cause an increased resistance to stretch. Reflexes can be brisk. There could be limitation in mobility. Your energy could be used up quickly because it takes much more effort to move along, and then pain and discomfort can occur. So with everything, there's non-pharmacologic and pharmacologic and surgical interventions. Stretching and exercise, positioning, seating, orthotics, and the therapy can be very helpful non-pharmacologic, non-medicine interventions. Under the pharmacologic bubble, there is a number of different medicines that are used. They're mostly oral medications. I will talk to you about the baclofen pump in the next slide. And there's also the botulinum that can be injected into certain muscle groups to decrease spasticity. The baclofen pump is what I'll be talking about here. This is a surgical procedure where a pump is implanted in the abdominal area, and there's a catheter, a rubber tube that's tethered into the lower portion of the spinal cord. And then the pump has a fluid reservoir where liquid baclofen is put in there, and small amounts of baclofen are distributed directly into the spinal cord area over a timed program or for precise dosing. This is for both ambulatory and non-ambulatory patients who are having a lot of difficulty with spasticity. Tremor in MS is caused by lesions in the cerebellum and its pathways, and it could affect the head, jerky movements of the head, the limbs, the trunk, eye movements, and speech. This is a very, very difficult symptom to treat, and the medications that we have are listed here, but they all cause sleepiness and drowsiness, but they may be helpful. It might be a good trade-off if a person has a lot of shakiness or tremor. Again, our friends in physical and occupational therapy can be helpful for these non-pharmacologic approaches. There could be weighting of utensils and assistive devices, help with coordination and movement, and doing different exercises to help. There is a extreme surgical intervention, a deep brain stimulation, not used as much anymore as it had been, but it certainly is possible for some patients if their tremor is very, very disabling. So in summary, the clinical approach to symptom management is specific and individualized, and it needs to be assessed and reassessed at every encounter with your healthcare providers. MS symptoms affect the quality of life of individuals with MS. left untreated, symptoms can worsen or precipitate other symptoms, producing this big cycle of interrelated symptoms. So please speak to your healthcare provider or your MS nurse about new or ongoing MS symptoms. A lot to cover there. Do I have any questions? Other questions? I don't see questions.
Maybe we can come back at the end,
Okay.
give some people time, and
Thank you.
and then maybe go from there, Marie.
Sounds good to me. All right. Thank you so much.
Thank you. Oh, we have one question.
All right.
He asked about the walking pill. You want to talk about that?
I will talk about it quickly. So the walking pill is called dalfampridine. It's a medication that can help improve the nerve impulses as they move along the pike. It's been out on the market since 2010, and it is now in generic form. Ampera is the brand name. Dalfampridine is the generic name. It's effective in about 30 to 40% of the people who take it in terms of improving their walking speed. That's what was tested in the original study to get it approved by the FDA. It won't help you walk if you're not walking now, but it can help individuals who are walking have a better ambulation. It's not approved for other uses at this time, but if you think about it, if it improves the conduction of nerve synapses, it may also be able to help with things like endurance and fatigue and that kind of thing.
Great. Okay. You ready, Steph?
I am, yeah. Thank you.
Sure.
Okay, so thank you, Marie. That was fantastic. And thank you for all of the examples. I think that really helps us to make use of that information for sure. So it's a pleasure to be here with all of you today. I'm really excited to be able to discuss some of the invisible symptoms that may occur in those of you who are living with MS. And I'll be able to review how nursing professionals and others within your healthcare team can also help you with managing some of these symptoms, really in an effort to reduce the physical and psychological impact that they have on your life. So moving forward, as you all likely know, the vast majority of symptoms that occur in MS are invisible. And when we say invisible, I mean those symptoms that are not seen when looking at someone who is living with MS. Many of my patients have told me that they've been told themselves, but you look so good. Unfortunately, they may not be how they are feeling. So unfortunately, it's these invisible symptoms that oftentimes become really the most impactful or have the most impact on those of you who are living with MS. So some examples of invisible symptoms include things that are listed here on this slide for you. Of course, fatigue. You can't always tell or see that someone is fatigued, but yet, as Marie mentioned earlier, this is one of the main issues, main symptoms that individuals with MS are living with. Pain is another potential invisible symptom that we, again, can't see, but people definitely can experience. Depression and anxiety, that's another thing that we certainly know is another invisible symptom, again, not always visible. And sometimes cognitive difficulties, you can't always tell. So these are some of the topics that we're going to focus on today. Specifically, we're going to focus on fatigue, pain, cognition, and depression. So let's go ahead and move forward, and we'll start with one of the big ones, which is fatigue. And you all, Marie mentioned this earlier again, this is really very common, unfortunately, but fatigue is defined as a subjective lack of physical and or mental energy that is really perceived by the individual or caregiver to interfere with usual desired activities. It's unfortunately the most common and disabling symptom of MS. We have this certainly to be noted in up to 95% of patients, and up to 60% describe it as their most troubling of symptoms. And this can certainly be reported in all disease stages and subtypes, meaning that you don't have to have had MS for some period of time. This can be prevalent from the very beginning. So MS fatigue is generally characterized by an overwhelming sense of sleepiness, constant sense of fatigue or tiredness, a lack of energy. Along with that, we can have a feeling of exhaustion. It's not necessarily related to a level of disability, so we don't see that those two necessarily go together. We can also see that there are effects in motor and cognitive function, meaning that as an individual is fatigued, they have worsening weakness perhaps, or more difficulties with cognition, more difficulties thinking. And the truth is it's truly not completely understood, meaning we don't know everything about MS-related fatigue that we wish we did at this point. So fatigue in those who are living with MS can have many possible causes. It may be MS related, or it may be unrelated to MS. So this is why it's so important that an evaluation take place so that appropriate management of the symptom can occur. As you can see here on this graphic, fatigue may be primary or secondary. Marie talked about this a little bit earlier. Primary meaning related directly to MS. And the truth is that the reasons for this are not exactly known. We don't know why with MS people have fatigue. I will tell you that many autoimmune disorders tend to have fatigue as one of their primary side effects, or primary symptoms, I should say. And we just don't know why. One theory is that MS is fatiguing because it's related to the general activation of the immune system. Another theory is that it's due to MS-related nerve damage. But the truth is we just don't really know why this occurs. Clearly, secondary fatigue refers to fatigue that's related to the effects of MS. So things like muscle stiffness or spasticity, pain or tremor, those things can be fatiguing. So those would be referred to as secondary MS fatigue. If you look at the physical health towards the right of the diagram here, this really is referring to other diseases like anemia or maybe hypothyroidism that can cause fatigue. We can also certainly see that sleep disturbances have an impact on fatigue levels. They can directly contribute to and cause fatigue. And along with all of this, there's just the normal fatigue that occurs in everyone. So this can also be another factor that contributes. And then, of course, certainly with fatigue, this can occur and be worsened by factors in your physical environment. I'm talking to you all from Texas, and fortunately, it's just now starting to cool off. But our summers here can reach temperatures of well over 100. And I know many of you may be joining from areas where heat and perhaps even humidity impact room temperatures or just temperature exposure in general and can cause fatigue for you. Certainly, stress, depression, and anxiety are some factors related to disturbance in physiologic health that can also induce fatigue. So what can you do to try to manage fatigue? I would say first off, obviously, discuss the issues with your provider and address those non-MS causes. Perhaps, anemia, maybe that's something that needs to be treated. Maybe there, again, is a thyroid dysfunction, hypothyroidism is certainly associated with causing fatigue, and so management of that can help. Or perhaps there's some depression or anxiety that needs to be addressed, because those two things in addition can also lead to or exacerbate fatigue. Another thing that's really right at the top of the list here, and it seems somewhat counterintuitive, I suppose, because if you're fatigued, the last thing you want to do is exercise. But what we actually know is that all modalities of exercise have the potential to improve fatigue in people who are living with MS. And so it's oftentimes difficult to get started with that regimen, the exercise regimen. But then once you've started that and once you've been doing it as a routine, people tend to report that their energy levels do improve. Some other suggestions include using cooling equipment. So here in my area, we have Dick's and Academies, sporting good types of places, and they both have what's called a froggy. It's a cooling towel. You dip it in cold water, you wring it out, you snap it, and it does stay nice and cool. It's certainly not going to be the end-all be-all if it's 110 degrees out, but it can be one of those tools that you can use to try to help you with managing the heat aspect of this. Another thing I would suggest is just making sure that you hydrate well with super cold fluids. This also talks about using therapy, so either physical therapy or occupational therapy. They can be really helpful for helping you with not only improving your endurance, but also with helping to teach you some techniques for conserving energy. And then also, of course, we want to pace certain activities, maybe prioritize those activities. And then lastly, certainly we want to try to manage stress, as we know that this too can cause some issues with regards to fatigue. So once we have tried all of those other interventions, what are some other things that we can do? Well, there are some medications that may help. And again, this is when fatigue continues despite addressing all of the other issues and perhaps using those other approaches. If you're still having issues with fatigue, then these options may be appropriate. Again, this is something that you have to have a discussion with your healthcare professional about. But you can see listed on the left side the different medications: amantadine, modafinil or armodafinil, methylphenidate, or other types of amphetamines. Of course, along with these, we certainly can see some benefits where it can really help an individual manage the MS-related fatigue that they're experiencing to the point where they are able to maintain the schedules that they need to maintain. But we also can see some certain adverse effects or side effects with these particular therapies. And so that's something that we always have to discuss and take into consideration when thinking about these particular interventions. So next, let's move on and talk a little bit about cognition. So cognitive impairment may be detected in over 30% of patients or people who are living with MS at the time of their initial diagnosis. And so I think oftentimes there is a misconception by many that cognitive impairments do not occur until later on, when in fact we can see them from the very beginning. And in fact, 65% will actually demonstrate cognitive dysfunction at some point in their experience with MS. And up to 15% will experience decreased job performance or altered social skills because of this. So unfortunately, we tend to see this, and it's something that we definitely want to address. We also can see that the occurrence or the prevalence of this increases with age and with duration of MS. When talking about the different types of cognitive deficits, these are listed here for you to review, and we refer to these as domains. And so we can see that along with the cognitive deficits experienced by those living with MS, we can see difficulties with memory. Okay, this is reported or noted in over 30% of those that are living with MS. We also see trouble with information processing. So this may be trying to learn a new task, but you're just having difficulties taking that information in that's being given to you and processing it. We can see that in over 25% of those individuals who are living with MS. Problem-solving difficulties can occur, certainly. And so trying to make a decision perhaps, or trying to figure out a certain task, that can be impacted. This also discusses visuospatial abilities, and so this would be the ability to, for some people, hand-eye coordination can sometimes be impacted. We can also see difficulties with concentration. I think for me, I actually would put this at a higher level than 10% because I have a lot of people who are living with MS that I provide care to who mention this pretty frequently. We can also see that verbal fluency is impacted. Now, one of the things to mention here is that 50% of those people who are living with MS will notice a deficit in one of these domains. We can see that multiple domains are impacted in over 22% of people who are living with MS. So when we're talking about the characteristics, it should be said that cognitive dysfunction does not correlate with physical disability. So this means that you don't actually have to have physical disability in order to have cognitive impairment or cognitive dysfunction. So with MS-related cognitive dysfunction, it can be subtle. And sometimes, unfortunately, it's underrecognized. It may be underrecognized by the individual who's living with MS. It may be underrecognized by family, friends, employers. And, you know, sometimes, too, as providers, we can also at times under-recognize this. And this is because we do have to really monitor and screen for this. If noted, it's really important for you to know that the deficits seen in MS, these are actually different from those seen in Alzheimer's. So that's just something important to be aware of. What we see with MS deficits, these are typically not diffuse, they're not global, and that's actually what we see in Alzheimer's disease. So these are different types of cognitive challenges. And we don't equate Alzheimer's disease with the cognitive dysfunction that can occur in MS. They're different altogether. So what do we do if we note that there's cognitive difficulties going on? If you, as a person living with MS, notes this, or perhaps you're a care partner and you notice this, so what can we do? And what can healthcare professionals do to help with this? I mean, I would say first off, each healthcare professional's way of evaluating this is different. But the first thing you need to do is make sure that you talk to your healthcare team about this, talk to your family about this, so that we can then pick up and kind of move on with the assessment and what we need to do. And what I will say is that each healthcare professional really evaluates cognitive status in a different way. And they also use a variety of testing tools. So you're not going to get the same evaluation from each individual healthcare professional. They may use different tools to do this, but they're all working to try to evaluate what cognitive issues are going on. And it's based on these tests that are then completed that we can really identify what true cognitive deficits there are, but we can also from that really figure out what strengths there are. We can determine the strengths. And when we figure these two things out, we can help to mediate or decrease the cognitive deficits by perhaps increasing the other strengths that can then take over for that. So along with all of this, the strategies for coping and for compensating can really be devised to help you as an individual who's living with this so that we can help you to manage as best as possible. Now, this talks about neuropsychological testing, and neuropsychological testing is very helpful for a cognitive evaluation. If any of you have ever had this particular testing, you know that it's a very long testing procedure. And when I say long, I mean it can take a couple of hours, several hours. But this particular specialist, they're specialized in behavioral changes caused by brain disease or by other kinds of things, and they help us to get a great picture of where, again, we have deficits and where we have strengths. They can also help to identify if there are no deficits. And I think for a lot of the patients that I see that have gone for this, it's been almost a comforting thing, because here where they thought they were having some cognitive issues, they actually found out from the testing that indeed they were not. So sometimes it can be really helpful for that aspect too. Additionally, with neuropsych testing, we can get some pragmatic or some practical suggestions for trying to help with managing the issues that are identified. So this is something that I think can be really helpful as far as like, what do we do next? This testing can help us with some suggested ideas for interventions. Many of you may know this neuropsychological testing can actually be helpful in supporting employment. And so that's another aspect of this that we can mention. And I should also mention that the availability of this type of testing can be limited based on where you live geographically, and unfortunately also it can be limited because of cost or insurance coverage. So how, let me see, did this move forward? All right, so what are some of the things that we can do? We talk often about disease-modifying therapies, and you all know that this may slow disease progression. And so this is certainly something that we need to really consider. So I think that typically we suggest getting on a disease-modifying therapy as quickly as possible, because again, we know that this can help to slow the progression that can occur. And so taking a DMT is generally suggested because research has demonstrated that these particular therapies slow disease progression. Along with that, counseling may be appropriate because cognitive issues are difficult to deal with and they can certainly increase stress. So I think counseling is just one of those things that can help us or help you to learn coping strategies. And that can be something that can be quite helpful for a lot of individuals. Cognitive therapy is another option, and this can be very helpful, as can some other therapeutic interventions that typically occur during cognitive therapy sessions. I would add to the bullet points here that as far as other things to help with managing this, explore some of those compensatory options that are available to you. So if you're forgetting where you place your keys or you're forgetting where you place your phone, try to make a regimen where you always put your phone or your keys in the same place every time. I think that can sometimes help with the frustration factor, trying to find things. If you're forgetting appointments, I've had patients tell me that they actually use their smartphone and they can talk to it and tell it to put in a calendar reminder or an alarm reminder for taking therapies or taking your medications or whatever. I think that's just another tool that frankly, I use myself because I have trouble remembering all of the different appointments that I have. And I think that that's a useful tool. Some other things to consider when you're trying to learn something new, give yourself some extra time because it may just be that you need a little bit more time to learn a task or to learn something new. And that way, if you give yourself some extra time, it can help to really decrease the frustration factor. I find that once you start to get frustrated with a task, myself included, I just can no longer learn because you stop taking in the information because you're frustrated. So giving yourself that extra space of time can help to reduce the stress and the pressure that you're placing on yourself. Few other things I would suggest are things like brain games, learning new tasks. We know that when you are learning new tasks, you are actually helping to create new oligodendrocytes. Healthy diet is really paramount. If you're a smoker, I would suggest you strongly talk to your healthcare professionals about trying to quit. Good sleep hygiene is another thing that can certainly help with this because fatigue can clearly impact your abilities to comprehend sometimes. And then lastly, exercise, another big one that we do have research to show that it can help with not only improving fatigue, but then also improving with cognitive impairments. So now I'll switch gears a little bit and let's talk about pain. I think there was some time ago, unfortunately, many years ago at least, maybe 15 or 20, where individuals were told that MS didn't cause pain. And you all know that that's completely inaccurate. Thankfully, with research and with advances in science and knowledge, we know that this actually can occur. And unfortunately, it can occur pretty frequently. So when we're talking about pain, it's important to recognize that there are actually two types. So you see here acute pain and chronic pain. Acute pain is the normal predicted response to some sort of noxious trigger. So say a cat scratch. that's a normal pain response. This is associated with something kind of invasive. So trauma, like a cat scratch, is generally what we see with acute pain is that it's time limited. So acute pain means that it's only for a short period of time. On the other hand, chronic pain tends to last. Okay, so it's not short-lived. It can last, in fact, constantly and permanently for an entire lifespan. So this is pain that lasts more than 6 months. It's generally ongoing. And it doesn't respond to treatment methods, or oftentimes doesn't respond to treatment methods. So those are the two types of pain that we're talking about. Now, specific to MS, let's talk a little bit more about this. So MS-related pain can and does absolutely occur. And unfortunately, it's noted in over 86% of people who are living with MS. So it's not uncommon, okay? More than 50% of MS patients find pain to be a problem. And for over 20%, it's a significant problem. Nearly 30% of all symptomatic treatment is related to pain. So when we're looking at the therapy that someone's on, 30% of those can be related to trying to manage pain. It is certainly under-recognized, and unfortunately, it's often inadequately managed. So the thing here is, though, that manageable in most patients. When we say that, there are things that we can do as nurses and as healthcare professionals to try to help with managing this, along with you, along with that in that same picture. So what are some of the risk factors for MS-related pain? Well, we see it with older age, longer disease duration, certainly with greater disease severity. Men and women are equally likely to experience pain, but women actually tend to have a greater severity of pain for some reason. We're not sure why that is. We also see that another risk factor for pain includes progressive forms of MS. And comorbid depression and mental health impairments can occur at the same time. So we can have pain, MS-related pain, and then on top of that, we add on depression and some mental health issues as well. So when we talk specifically about the subtypes of MS-related pain, I'm just going to go over these with you because these are medical terms, but just to kind of give you an idea, we're really referring to different types of pain. So we see continuous neuropathic pain. And when we talk about continuous neuropathic pain, this is just giving you some examples. So numbness, burning, and then this says dysesthetic extremity pain. And when we see we use these words, they have their roots in Greek and Latin terminology. And just to kind of give you an idea, dysthenia is actually the Greek word for our word root is dys, meaning not normal. And then aesthesis, which means sensation. So basically what we're saying when we say dysesthetic extremity pain, we're saying an abnormal, painful sensation to an arm or a leg. Okay. We can also see different types of pain like intermittent neuropathic pain, such as trigeminal neuralgia. So this is that electrical shooting discomfort that can travel down the jaw, the cheek, or up to the forehead. Lhermites, of course, this is when you might tilt your chin down, and with that, you might notice this electrical shooting sensation that travels down the spine. We can also see this type of pain because of spasms. So painful muscle spasms can certainly occur. Some examples of musculoskeletal pain include pain to the bones, the muscles, and the joints. And an example of a mixed neuropathic and non-neuropathic pain, this would be something like a headache. So these are just some subtypes of pain that can occur and can be seen when we're talking about multiple sclerosis. So we certainly do have some medications that can assist with managing pain. We likely would try some other interventions prior to this, but this is just to give you an idea. There are therapies available. There are medications available, and these are listed here for your review. Things like gabapentin, carbamazepine, amitriptyline, topiramate, pregabalin, duloxetine. These are all medications that we oftentimes will use in our arsenal of trying to help with managing the MS pain that can occur. You should know, of course, that with any of these particular interventions, there are potential side effects and certain adverse reactions that can occur, and those are listed on the right side. So we can see, unfortunately, fatigue with this. We can see dizziness. We can see dryness, mouth dryness, constipation. Here we are, we're trying to manage one particular symptom, right, pain, and then here we can have all of these other potential side effects. But work with your healthcare professional, because there are things that we can do. Sometimes it's just a matter of tweaking a medication, using a lower dose, so these or potentially changing to something that's better tolerated. So make sure you have that open communication with your healthcare professional to help you with those types of treatment options and side effects. So what are some other methods for assisting with managing pain? Typically, I will say these are the things we do first before we start talking about medications, or we do it in addition to, right? So there are certainly a number of non-pharmacologic management strategies, and all of these may help alleviate pain in MS. Stretching for spasticity can certainly help to reduce the tightness and muscle tightness and the pain that goes along with that. Massage is another intervention that can be quite helpful. Distraction therapy is something else that I think if you were to talk to behavioral scientists, they would tell you that this has been researched quite a bit and can be quite helpful when you distract yourself from recognizing the discomfort or the pain. Acupuncture, this is something that's been used for well over 2,000 years and has been found for many people who are struggling with MS-related pain to be helpful. Guided imagery is mentioned here. That's another intervention that can assist. And certainly chronic pain management programs. Those have really resulted for many individuals in significant improvements in pain. And unfortunately, pain can be depressing. Pain can be fatiguing. It can cause anxiety. And so that's where this chronic pain management program can really assist. And frankly, with that, it helps to teach adaptation and some stress techniques, stress reduction techniques, and relaxation techniques. And so all of those things together can really help with assisting with managing pain. I would also encourage adequate rest. I think if people are tired, their pain tends to increase. And then this also mentions PT and OT. Those two therapeutic options can be quite helpful as well. So let's talk a little bit more about depression. This is another invisible symptom. You can't always look at someone and tell if they're depressed, right? So this is actually it is the final symptom that we're going to talk about today. So let's talk about depression in more detail. So depression is not always visible, as you all know, but it can have negative effects on the individual who's living with MS and their loved ones, their family. It can just affect so many things broadly. But we talk about depression, but what is it really? We say depression, what does that mean? Well, according to the World Health Organization, this is a common mental disorder characterized by sadness, loss of interest or pleasure, feelings of guilt or low self-worth, disturbance of sleep or appetite, feelings of fatigue, and poor concentration. Okay, so that's how the World Health Organization describes this. When you're talking to your healthcare professional, they may not say, "Are you depressed?" They may say something like, "Have you been having feelings of sadness? Have you been having feelings of hopelessness or helplessness? Has your energy level been decreased, or have you been sleeping more?" These are the kinds of questions we typically ask, because sometimes, just saying, "Are you depressed?" Well, I think Denise mentioned this at one point earlier. That doesn't necessarily mean that you're having suicidal thoughts. It can just mean that you are feeling sad. And so these are the kinds of things that we always want to tease out and discuss so that we can address them as possible. Now, 50% of people who are living with MS will experience depression. Incidence of depression is 3 times greater than the general population. So depression is common in the general population. I think about 45 to 50% of the general population has some depression. So think about that. depression is 3 times greater than in the general population in those individuals who are living with MS. We just don't know what the cause is. It could be related to MS directly. It may be some sort of pathophysiological issue. It can also be related to medications that are used to treat MS. Some of the disease-modifying therapies, we have to be cognizant of that. They have particular side effects, so we have to be cautious. Or frankly, they could just be related, the depression may be related to the challenges that you experience as a result of living with MS. Now, the depressive symptoms, the presence of these, they don't actually correlate with severity of disability. I've seen individuals who have little to no disability, and they definitely agree that they have depression. And then I've also seen kind of on the other end of that spectrum, people who have severe disability and they do not show any evidence of depression. So those two things don't necessarily go together. Suicide has been indicated as a cause of death for up to 15% of people who are living with MS. And depression continues to be underdiagnosed and undertreated, which is, again, why this is one of those things that as nurses and healthcare professionals, we need to make sure that we screen for this. And we want to make sure, that we talk about it. And I'm hopeful that you have a relationship with your MS specialists and your healthcare team, that you can discuss this if it's a concern of yours. So what are some of the clinical characteristics that we see? I mentioned earlier, feeling sad or empty, and irritability, crying, jags. We can certainly see that those are some of the characteristics that go along with depression. Loss of energy is another one of those symptoms that we tend to see in individuals who are living with depression. Loss of interest in things that you generally used to bring you joy. That's another telltale sign that we need to really evaluate things. If there's a change in appetite or weight, either eating more or eating less, or weight loss or weight gain, those are some potential characteristics that we can see go along with this. Unusual sleep behaviors, sleeping 15, 16 hours a day. So we call that hypersomnia, a lot of sleep. That can sometimes suggest that there's a depression that's going on. Decreased sex drive or decreased libido, that too can be a sign, and certainly suicidal thoughts. These are all potential clinical characteristics of depression and things that we definitely want to be cognizant of and be aware of. So what approach do we take together to try to manage depression? I would say that it requires working together with your healthcare team, and it also often includes working with your family, your significant other, as a team together to try to work through this. I think a multidisciplinary health team can use many non-pharmacological management strategies when treating depression in people who are living with MS, and these would likely include things like offering a supportive therapeutic environment, identifying risk factors for depression, providing psychotherapeutic services, perhaps the talk therapy we talked about, the cognitive behavioral therapy that we talked about. And then in addition to that, I think also just really encouraging a healthy lifestyle. Physical activity has been found to help with mood and depression. So that's another potential intervention that can really assist with this. Again, along with all of this, maintaining vigilance for suicidal ideation or plans, and then continuously reassessing the mental health, of those who are living with depression and MS is certainly suggested. There are also certain medications that we can utilize, and this isn't, again, in addition to all of those other types of interventions. I would not suggest just a medication. I think that this is something that we need to do some non-pharmacological interventions for, in addition to sometimes using medications. And we actually have research that shows that when we do both, the medications along with, say, talk therapy, our outcomes are much improved when we're talking about managing depression. So let's talk a little bit about the different medications that are available. These listed here for you are broken down into different types of categories as far as some are selective serotonin reuptake inhibitors, and those are listed here as far as fluoxetine and paroxetine, also notes the dosage. And again, we can have potential adverse effects or side effects, including nausea, insomnia, diminished libido. And then we move down to the SNRI. So these are the selective norepinephrine reuptake inhibitors like venlafaxine and duloxetine. And with those, we can potentially have some side effects or adverse effects, including nausea, dizziness, nausea, and insomnia. So with all of these, we have potentials for side effects. But what I would encourage you to do is this: talk to your healthcare professional. My experience is that typically people tolerate these pretty well. And if they don't tolerate one, oftentimes they tolerate another one better. Or if they find that one is not as effective for them after a reasonable trial time, then we can work together to find one that maybe is more effective. So that's what I would just suggest. Okay. So with that, it's been my pleasure to speak with you all about some of the invisible symptoms that occur in MS. And I would encourage all of you to really work together with your healthcare team to make every effort to manage these in an effort to reduce the physical and psychosocial impact that they may have on your life and on the lives of your loved ones. Typically speaking, we as nurses and healthcare professionals can help. We can't always make all of these symptoms disappear. Even though they're invisible, we wish they would disappear. But we oftentimes can help to reduce them and to really help to manage them. And that's certainly something that we hope that you reach out to us for if you feel like you're needing some assistance with this. I think I will leave you just with a couple of additional thoughts. I would encourage all of you to exercise, maintain a healthy lifestyle, so diet, of course, quitting smoking, limiting alcohol, manage stress. And if you're not sure how to do that, ask your healthcare professional about that. There are so many apps now online that I found to be really helpful for many individuals, people who are living with MS and people who are not, that are trying to manage stress, especially in this time of coronavirus and everything else. So reach out and look into some of those interventions. Make sure you get good, adequate amounts of sleep. We are, by nature, humans require 7 to 8 hours per night. And that's what we want, is that to be as uninterrupted as possible. I think that in the United States in particular, we think that we only need 4 to 5, and it's just not adequate. Think of your sleep time as a time for your brain to recharge. You charge your phone at night, charge your brain at night by getting good sleep. I would also say that what we know is this: lifestyle matters and can have either a negative or a positive effect on those who are living with MS. So this is something that you have to do in addition to all of those other interventions that we talked about. And again, talk to your healthcare team and gauge the impact of your symptoms on your lifestyle. If you're not having issues, that's fantastic. But if you notice that something is impacting your ability to work or to enjoy life or to do the things that you like to do, let us know. And maybe we can assist with that. Okay. Should you have a symptom that is new or suddenly worsening, evaluate potential contributing factors and then talk to your healthcare professional about it. And last slide, I just want to give you a couple of resources that might be helpful to you. And these are listed here for your review. The Multiple Sclerosis Association of America, there's the internet address for it, also the MS Foundation, and along with that as well, we see the National MS Society. So those are just some resources that I think can be quite helpful for people who are living with MS and for their family and friends. There's a lot of information on there that has been compiled by people who are really truly experts in the world of multiple sclerosis. And so with that, I think we are going to open things up to questions.
Excellent. All right. So we have a couple. Can you hear me, Steph?
Mm-hmm. Yes. Marie can too.
Okay. Great. Thanks, Marie. So we have a couple questions that people have written in. So first one is it normal to get complete short-term memory loss with MS?
So I guess I'm not sure what they mean by complete short-term memory loss. I mean, short-term memory loss that I typically see is, again, kind of people forgetting where they put their keys, people forgetting, the ending of a movie, maybe, forgetting, usually for me, it's about where they put things. I see that quite a bit. But short-term memory loss, I guess I don't know what you mean by completely. So Denise, what do you think that's referring to? Like everything short-term is gone? Because I would say, no, that's probably not normal MS.
Yeah, I would agree. I think MS or not, we forget somebody's name when we see them, or word, we want to use complete short-term. Did I have breath? Or what is this device? That's not typical MS memory loss. So I think, again, when somebody tells me that they're with memory, I kind of like to tease it out. Alzheimer's is very different than the memory issues, cognitive issues we see with MS. It doesn't mean that having one is mutually exclusive of having the other. So this is oftentimes where neuropsych testing can come in to get a baseline, to reassure a patient, and to give perspective on what we're actually dealing with. Marie, do you have any thoughts?
No, I totally agree. Severe memory loss, short-term memory loss, if that's what it is, really needs further evaluation. MS certainly can cause some short-term memory loss, but it doesn't affect the whole day. It's not like every day is a new day because you don't have any memory about the recent past. So that does need further evaluation.
Yeah. Another question somebody asked was forgetting how to spell with cognitive issues. Have we seen that with patients?
So I will just say I don't see that as often as I see difficulties with word recall. I see that way more often than I would say that I see people having difficulties with remembering how to spell a word. Typically what I'm seeing is people can't remember which particular word they are trying to say. And I think that that has to do with, we have these memory files in our brains, all of us. And when you're living with MS, sometimes it's just more difficult to recall or to retrieve that particular file for a word. So you may be thinking dog and you can't find that word for whatever reason in your file cabinet. I really don't see forgetting how to spell. That's not something that I've seen in my experience.
I have not either. That's probably yeah, go ahead, Marie.
Some of my patients had difficulty recalling a letter of the word, and I don't know if that's what that person is referring to. And that, again, is part of that processing, but not necessarily how to spell exactly. They may forget that particular vowel or that consonant that they need to put in the word.
Yeah. So, that is part of the mini mental, is spelling words, forward words, that kind of thing. To me, that's a different cognitive. Okay, another question that came in: how are we providing care, evaluating patients during the pandemic?
So this is Marie. I could start. From mid-March until June, we were pretty much doing all virtual care. Most of it, however, was video, as we have the capability to do that for our patients. But, mostly it was conversation because you couldn't do as much of a physical exam as I, old school nurse, like to do with patients, having them walk down the hall, monitor what their walking looks like, checking their vision, checking their hand function, etc. But then in August, we went back full force into the office. So we are seeing people in person and are able to do much of the neuro exam, but again, not as complete as I would like, because checking for hand dexterity with a 9-hole peg test or the box and blocks means that everything has to be washed and cleaned, and so that doesn't happen as often. And, you know, the touching of the patient, unfortunately, has decreased. And I'm old school again, and that was meaningful to me to be able to just have that interaction and that pick up on those nuances of the neurologic exam.
Yeah, agreed. I think since this is a illness, we know our patients so well, and so many of them hug or we shake hands, you know, and so that's sad, but it is to kind of be back in person. Mask, still not the same. We're wearing masks in our facility. In some ways, doing full visits, exams, you can still see the full person, see what's going on kind of around them, but you're right, we're not able to touch, obviously, get those details of the examination. But we're doing a hybrid of in-person and then video appointments as well. How about you, Stephanie?
Yeah, we are still mostly doing televideo. However, in those circumstances where we need the patient to come in for procedures, obviously, but also because of a particular concern, we're certainly seeing them then in the office. So it's a little bit of both, but I will say in my area, we're still predominantly doing televideo. And I think with the majority of medical facilities and clinics, they are still doing it the same way, televideo right now. And again, that comes with a lot of different constraints that we've had to learn to work through. As Marie mentioned, you know, we can't do a physical exam, but we are able to ask a lot of questions. I find that we're actually able to spend a bit more time with people because we are doing televideo. So we aren't waiting for our medical assistant to get someone into the room and to, you know, to do all of those things, because all of that, first of all, they're not being placed in a room. So all of the pre-stuff is happening before we even go on with them. And so we actually have a bit more time sometimes to be able to discuss different issues. And I think it comes down to really being certain to do a good review of systems to see how someone is truly doing and asking lots and lots of questions.
Yeah, great. Okay, I think we have one more question here. How often should a person be evaluated for physical fitness? So to me, physical fitness is regular exercise, is how I would interpret that. And this is another question that I usually ask my patients every visit. You know, how are they sleeping? How's their mood? How's their bladder? What are you doing for exercise? And it's interesting what people will say and what people interpret that to mean. So exercise is intentional movement of the body, and it's something everybody can do in some format if they're not completely able. There is some physical exercise out there that can be done. So sometimes it's sometimes is turning patients on to different resources out there. A lot of these things that we talked about today in terms of symptom management, exercise and movement was listed as a treatment for almost every single thing that was listed. So I would say my answer would be every visit pretty much I'm evaluating that.
This is Marie, and I totally agree. Exercise is part of the wellness piece, part of what people can do for themselves to try to stay as healthy as possible. I mean, any type of structured activity other than work that a person does 10 minutes, 15, 20 minutes a day, you know, that is a planned activity different than what they normally do, counts as exercise, as you said, Denise. When I was working at home, I signed up for this 7-minute yoga workout for older adults on my YouTube, and I faithfully did it, and I asked many of my patients to do it. It's a stand-up yoga. It was easy to do. It was good stretching and breathing and good for stress reduction. So I was sold on it. I try to sell patients on seeing a physical therapist, though, if I feel that they've been deconditioned, as kind of a tune-up, and get back on a program. So it's very important, is the short answer.
Well, I don't see any other questions in the right at time much for listening. Hopefully everybody learned something. I was learning from listening to patients, seeing what questions are being asked, and to listen to colleagues. Thank you. Hopefully we will secure funding to continue to do programs like this, especially during the pandemic, because I think there's people from all over the country that were able to log in today. Yeah, so have a great day. Thank you, everyone. Thank you, Stephanie. Thank you, Marie. Thank you for everybody at Neurology Live. And have a great weekend.
Thank you all.
Thanks so much. Thank you.